Okay, this video is about a couple insights on brain capillaries. Now, you've probably already seen this slide before if you've seen a lot of my videos, but this is just the work of Jack Delatorre, tying off the internal carotid artery in a mouse, and about 2 months later, a middle-aged and older mouse would become demented. The younger mice did not become demented, thought because they've got more physiologic reserve, more endothelial nitric oxide vasodilator, for example, and just simply the ability to handle the ischemia both in their cells and their vasculature. Okay, there's mouse equivalents, things that will also cause chronic cerebral hypoperfusion and can cause dementia. Okay, and that's the Jack Delatorre theory of chronic cerebral hypoperfusion, also called the vascular hypothesis of dementia. And what it kind of comes down to as well is here's the internal carotid artery going up into the brain. This is a coronal view, meaning the person is facing you. The internal carotid artery bifurcates into the middle cerebral artery here. These branches to the basal ganglia are called the lenticulostriate arteries. It then extends up around the convexity, the convex outer surface of the brain. And you have these deep penetrating arteries. And this right here is sort of the center of the brain. In between the lenticulostriates coming from below and the penetrating arteries coming from above. And the point is it's sort of an end artery territory, meaning there's not a lot of collateral flow. So if there's a low blood pressure, you might not get enough blood to this spot. The reason why you don't want excessively high blood pressure, though, is you can shear off the origin of these lenticulostriate arteries and have small bleeds in this area. Those are typically called lacunar infarctions with hemorrhage, like a microbleed, for example. It's typically small hemorrhages, or hemorrhagic lacunar infarctions would be a typical way to describe them. I see those every day. Okay. I see these, though, much more commonly where there's a lack of blood flow reaching the deep white matter adjacent to the lateral ventricle. This, by the way, is called centrum semiovalle, up above these lateral ventricles in blue, corona radiata at the level of the lateral ventricles. I'll very often see 10, 20, 30, 40, 50 or more small silent strokes from what is thought to be a lack of perfusion of this area of the brain, end artery territory. It can be due to chronic hypertension damaging these arteries, thus decreasing their ability to deliver glucose and oxygen, or it can be because of hypoperfusion, pressure in the carotid being too low. We've got elastic fibers in our ascending thoracic aorta. Normally when the heart contracts, cardiac systole, the ascending thoracic aorta stretches outward. Then the elastic fibers during cardiac relaxation, called diastole, they recoil inward, and that generates diastolic flow, which helps to maintain good blood flow during the diastolic phase of the cardiac cycle. So cardiac cycle is systole, contraction of the left ventricle, and then diastole, that's going to be the relaxation of the left ventricle. And that's a good thing. So the total pressure doesn't have to go that high when the diastolic pressure is reasonably good. However, what typically happens is people eat high-fat diets, high-sodium diets, and they'll have high blood pressure from a young age that's going to overstretch these elastic fibers in the ascending thoracic aorta. The ascending thoracic aorta is really like a second heart. And this ability of elastic recoil to generate flow, a compressive effect, is called the Windkessel effect. So when you lose the elastic fibers, you lose the Windkessel effect. And in order to generate the same amount of flow going up to the brain, for example, you have to have a higher systolic pressure. So that's what leads to systolic hypertension on a chronic basis. Okay, we talked about fat, for example, or fibrinogen, LDL cholesterol, sticking the red blood cells together, making it harder for them to pass through the capillary, increasing the thickness of the blood, also called the viscosity of the blood. So again, blood pressure has to go up to pump thick blood. Okay. Normally flow is laminar, meaning the red blood cells are in the center. It sort of has a parabolic velocity profile. White blood cells adjacent to it, and then the plasma on the outside along the endothelium, the lining cells of the artery. By the way, the main purpose of this video is I'm going to get into some stuff about regulation of flow in the brain itself, autoregulation, and a very interesting thing. So this is sort of just the intro for people who haven't had it before. But for those of you who've seen this before, I'm going to get to something really interesting, an AO, academic orgasm, but I kind of have to go through this for the person who's new to. Okay, these are the bridging molecules, things like LDL cholesterol, fibrinogen, uric acid, IgM antibodies. They stick the red blood cells together. Red blood cells have a negative charge on their outer surface called a zeta potential due to things like sialic acids and cholesterol sulfates. And they just help the red blood cells to repel each other so they don't stick together. The higher the LDL cholesterol, the higher the blood viscosity, meaning the thicker the blood, the more likely the person's hypertensive, and the more likely they're going to get atherosclerosis. There's a very strong connection between total cholesterol, LDL cholesterol, and atherosclerosis. atherosclerosis. So don't let anybody tell you otherwise. There's a lot of nonsense on the internet that tries to confuse people about that. Okay, when you eat a high-fat meal, you get a lot of fat in the blood. So here's, let's say, normal blood, relatively yellow, translucent plasma, versus when they eat a high-fat meal, this becomes relatively opaque. And in the movie Game Changers, they had a nice picture of it. You can see the actual test tubes after they drew blood from the men, and they'd had fat meals, for example, in comparison with not fat meals. Okay, Peter Cole in the 1950s, and then in the 1960s, Meyer Friedman and Ray Rosenman did these experiments where they would draw blood from the patient's arm every 30 minutes after having them eat a high-fat meal. In the 1950s, they ate a saturated fat meal, and they typically get, pretty marked hyperlipidemia, high fat levels in the blood between about 4 to 7 hours. And at the same time, these are patients who had a history of chest pain, shortness of breath on exertion, dyspnea on exertion due to coronary artery atherosclerosis, narrowing. And they would tend to get episodes of chest pain, angina, chest pain, when the fat in the blood was highest. So peak lipemia, lip is blood, emia means in the blood, so at highest fat levels in the blood. Then in the 1960s, in the 1950s, Ansel Keys had shown, saturated fat's a major risk factor for coronary artery disease, saturated fat, total cholesterol levels. So what happened was in the 1960s, there's a big push to unsaturated fats, to increase those in the diet, like your omega-6 cooking oils. And that turned out to be another big disaster. What they found in the experiments is that unsaturated fat, the PUFAs, polyunsaturated fatty acids, they're also called omega-6 fatty acids, cooking oils, they caused even more prolonged thickening of the bloods. They all call that blood sludge or rouleau formation. Rouleau means stack of coins in French. Okay, normally your endothelial cells are shaped like spindles, and they're orientated with their long axis in the same direction as the blood flow. So here's the direction of blood flow, and here's the long axis of the spindle-shaped cells. Here's an individual endothelial cell, and the most important thing to know about it is that it makes nitric oxide. So the nitric oxide is a gas. It diffuses into the lumen of the artery where the blood's flowing by, and it inhibits the platelets, prevents them from clotting. That's a good thing. It also diffuses posteriorly into the wall of the artery to the smooth muscle cells, and it gets them to relax. You don't want the arteries, if you want to increase flow, you want these cells relaxed so the diameter of the artery will be wider. They enclose the artery in circumferential fashion such that when they contract, they constrict the artery. They make it more narrow. In addition, you have an endothelial glycocalyx of glycoproteins, and you'll have on there things like heparin sulfate with antithrombin 3 attached to it, which is also very antithrombotic because you don't want clots forming on your the endothelial glycocalyx itself will have a negative charge on it, which also repels the RBC zeta potential as well. Okay, so that's just normal endothelium, antithrombotic. When blood pressure comes up, okay, so here's the blood coming up. It'll hit the median divider. This is the internal carotid artery going to the brain. Here's the external carotid artery, goes to the face. And this happens at all bifurcations. There's a median divider of tissue, and the laminar flow coming up at the divider will hit the median divider and bounce off of it. So it's normal to have some turbulent flow because of that collision. It's normal to have some retrograde eddy flow. Retrograde eddy currents mean retrograde flow. However, when the blood pressure is high, excessively high systolic pressure, it hits this median divider harder at a faster velocity. So you'll get an increased amount of turbulent flow. You get an increased amount of retrograde flow. And that is confusing to the sort of like sensory hair cells, cilia-like cells, if you will, in terms of how the endothelial cells sense direction of flow, and related to their glycocalyx. Okay, so the point is it confuses the endothelial cells, and they will shed their antithrombotic glycocalyx, and they will then have expressed relatively prothrombotic components of their glycocalyx. And that will cause clots to form on this side. It'll be the side away from the median divider. Okay, that's another important point. Atherosclerosis is a blood clot. That's an important thing to know. It's called atherothrombosis theory. I look at CT angiograms every day. It looks like a blood clot. It is a blood clot. All right, so anyways, little pieces can break off and go distally and cause a stroke. The body's constantly in steady state, trying to repair these things. So you want to help your body get ahead of them and control them so they don't progress and lead to strokes. Okay, so now here's the cool part. Now here's why I'm actually giving this talk. When the neurons are active, they will use up more oxygen, they're going to release more CO2, and they also release more potassium. And that potassium goes and binds with potassium receptors of the arterial wall, and they send a signal for it to vasodilate. And what's interesting about it is these endothelial cells, these sort of like bluish purple cells right here, they are connected to each other with these transverse gap junctions, okay? And that allows current, electrical current, to pass between these endothelial cells. And what's fascinating about it is they will send a wave of vasodilation passing proximally. So what they're doing is they're saying, look, we are very active at this moment, so we need more blood supply, we need more oxygen delivery, we need more glucose delivery. And they're able to transmit that need by sending a communicating amount of electrical flow through this area here, okay? So that's rather fascinating. And they can send this back. So that's going to be what's called retrograde vasodilation. Now, if you're walking down a path in the forest and you're just having a good time, bird watching, looking at the birds, talking about the birds and the ecology and the nature, everything is calm and relaxed. Your brain cells only have a mild level of activity. But if all of a sudden you see a couple coyotes and you know 3 coyotes and they start walking towards you, you're scared, okay? Do I need to run? Do I need to stare them down, fight them, climb a tree, whatever you're going to do? So these brain cells are going to become very active, the ones observing the coyote and getting ready to run, for example. So they're going to send this message of retrograde vasodilation to dilate these arteries so they can get more blood flow because they're going to need it. So that's how one of the ways that the brain can ramp up very quickly and increase blood flow locally to the spot that needs it. That's actually a really cool thing. And then the other relevance of it is if you damage this blood-brain barrier between the blood and the brain due to hypertension, due to atherosclerosis and diabetes, and you get increased blood-brain barrier permeability from high-fat diets and whatnot, you're going to make it harder for this message of retrograde vasodilation to be transmitted effectively. And it's, in addition to being between the endothelial cells, it's also involving, of course, the vascular smooth muscle. At the level of the capillary, they'll call the vascular smooth muscle cell pericytes, but you can think of them as being vascular smooth muscle cells. Okay, so if you mess up the ability to transmit these messages posteriorly effectively, it's almost like having atrial fibrillation in the brain, which I say as a joking matter. I don't want to confuse you. I'm just saying that as a joke. But you get my point. This is a delicate, nuanced symphony of communication to make everything correct, to orchestrate neurovascular coupling, meaning the vascular coupling to the neuron activity. Okay, so that's an interesting thing. Okay, so here's the consequences of diabetes and hypertension. Here's a normal capillary in the brain. Here's the red blood cells passing through. They're a little bit bigger than the capillary. Let's say they're about 7 microns. Capillary is about 5 microns in diameter, so they have to deform themselves, bend back on themselves a little bit to pass through here. Here's the endothelial cells lined up in spindle fashion along the long axis of the capillary. The green cells are the vascular smooth muscle cells. The yellow is the endothelial basement membrane. And so what's the point? The point is oxygen moves from the red blood cells to the neuron to supply it with oxygen. However, when you got chronic diabetes, you get thickening of this basement membrane of the endothelium. And when it's thicker, it's harder to deliver oxygen across it. You'll get hypertrophy of these smooth muscle cells, and that creates an increased thickness to deliver oxygen across. In addition, you'll get some collagen laid down. Now, collagen is also called fibrosis, scarring. And this can all make it more difficult to deliver oxygen to these neurons. So the neurons at increased risk to be ischemic, meaning have an undersupply of oxygen. Okay, so over time, chronic hypertension damaging this arterial wall, chronic diabetes damaging this arterial wall will make it more difficult to deliver oxygen to the neurons. In addition, we don't need to get into all this stuff, but the neurons do not have glucose type 4 transporters. They have glucose type 1 transporters, meaning that they just sort of take whatever glucose is in the blood. So chronic hyperglycemia, chronic high blood glucose levels due to diabetes will cause an excessive amount of glucose to come into these endothelial cells, and that will damage them. Okay, it's like a microvasculopathy, injury to small arteries that occurs in diabetes, and that'll further damage the ability of the neurovascular unit, the capillary, to couple neuronal activity to oxygen and glucose delivery. And over time, that can lead to an undersupply of oxygen and glucose to the neuron with subsequent death of the neuron by apoptosis. Okay, it needs adequate oxygen and glucose to survive. There's just a little more detail about this wall. So here's a neuron, the brain parenchyma. Here's the astrocyte, the supporting cells like the mama cells that help keep the neurons alive and do a lot of work to help them out. Here's the pericyte, like I said, like a vascular smooth muscle cell. There's tight junctions between these endothelial cells. Endo means inside, so the inner lining cells of the artery. You can see the gap junctions across them. Now here's where there's damage. You've got blood-brain barrier dysfunction with gaps between the endothelial cells, so toxic chemicals can leak into the brain parenchyma and be disruptive to it. They can cause problems with the local milieu of the neuron. It has to function in a milieu of electrolytes to provide with optimal ability to conduct an action potential quickly. Okay, endothelial cells, when they're injured, they can become distorted and have a damp-like effect, damage-associated molecular pattern, and that can even cause an immune response. Okay, but we're not going to get into that. That's not our main point. A more relevant thing is you can get upregulation when you've got chronic injury to the arterial lining in a demented patient. Let's say it's with so-called Alzheimer's dementia. You'll get upregulation, meaning an increased amount of RAGE receptors, and that really means receptor for advanced glycation end products, which come from, diabetes, advanced glycation end product. We call them AGEs. But those will also, so here's the receptor for advanced glycation end products, RAGE. They will also transport beta amyloid protein from the periphery into the brain, and you don't want that. You want to be clearing the beta amyloid protein out of the brain. On the other hand, you got these guys right here, the LRP1 receptors, and they normally transmit beta amyloid out of the brain. Okay, but when you got the chronically ischemic, diabetic, hypertensive endothelium, you'll downregulate these, meaning decrease the number of these transporters for moving beta amyloid out of the brain. You want beta amyloid to be removed from the brain and then sent to the liver and the kidney to be excreted from the body. Okay. In addition, the astrocytes will make the apoproteins, the ApoE proteins, and if you've got, homozygous ApoE4, you're going to be less able, like here's ApoE made by this astrocyte, you're going to be less able to get the beta amyloid out of the brain, and it'll have a tendency to accumulate in these endothelial cells. And you got this letter here, it says CAA for cerebral amyloid angiopathy, and that'll also limit gas exchange, and it makes these capillaries more predisposed to bleed, like cause cerebral microbleeds, for example. So cerebral amyloid angiopathy is considered a so-called subtype of so-called Alzheimer's dementia. Okay, and I do see a lot of microbleeds in brains. I see a bunch of those every day. Okay, here's a little more about the neurovascular unit, meaning the capillary unit in the brain. Here's the neuron itself. That's the cells that send the electronic messages for communication, for thinking and whatnot. Here is the endothelial cell, this red sort of maroon cell outlining the center of a capillary right here. Here's the pericyte in green in this drawing here, and those are the vascular smooth muscle contractile cells. Here's the astrocyte, the mama helper cells with their little foot plates. Let's see, and we talked about the endothelium having glucose type 1 transporters. Okay, that's all we need for now. All right, there's something really good on this slide. So here's a normal capillary in the brain, like we've just been talking about. Here's the LRP receptors. It's sort of like the LDL-like receptor-related protein that transports beta amyloid out of the brain into the blood. That's what you want. And then here's the bad one, the receptor for AGE, which transports beta amyloid in the opposite direction, from the blood into the brain parenchyma. You don't want that. But really, the most important, most interesting thing about this slide is showing how when you have a breakdown in the blood-brain barrier, as commonly occurs in the setting of high-fat diets and hypertension and diabetes, you can get some fibrin. That's the clotting protein from the blood. Same thing with thrombin. They can get into the subendothelial space, deep to the endothelium in the brain parenchyma itself. And that's highly relevant, especially with the work of Douglas Kell and Atherosclerosis pretorius with regard to leaky gut and amyloid-like clotting. So I made entire separate lectures on that, but the point I wanted to make was fibrin can get subendothelial. And when it becomes subendothelial, it can interact with these beta amyloid proteins and cause them to precipitate, essentially change their structure from alpha helix cylindrical into a beta pleated sheet, flat like a piece of paper. So the bottom line is it makes them stick together and puff up, and when they puff up, they can have mass effect on other structures. When they're in the so-called early phase, the oligomer phase, that's thought to be the main time they can push on the NMDA receptor and cause increased calcification, calcium, to go into the cell, into the cytoplasm, and that's bad. You don't want abnormally increased cytoplasm concentrations of calcium. When they get even bigger, they can push on other beta amyloid and cause them to, it is thought like a domino effect, to precipitate, and that's like a prion-like mechanism. So prion mechanism is very similar to the concept of amyloidogenic clotting, that you change the structure of the protein from from alpha helix being like a cylinder, like a slinky, into something flat like a sheet of paper. And when they're flat like a sheet of paper, they stack up more readily. And when the molecule gets bigger and bigger, the bigger the molecule, the more likely it is to precipitate out of solution, become insoluble. And it can also, of course, have mass effect on other things. And that would be a mechanism whereby something that you would think is, lifeless could have an effect on other things by it being able to increase in size, like a snowball rolling down a hill, for example. So anyways, I just thought this was a cool slide because it, shows the fibrin and the thrombin clotting proteins getting subendothelial, where other papers show all the problems that can cause. So all this stuff contributes to making people demented. So basically, before your age 30, your body's got so much reserve. It's pretty good at repairing things, even if you have a lot of bad health habits. But the older you get, the worse it gets, the more fragile you get. So you're basically almost like having a battle from the age of 30 years old to 60 years old, like a 30-year battle to try to protect this wall, this blood-brain barrier. Just like you don't want to have leaky gut on your intestinal tract, you don't want to have a leaky blood-brain barrier. There's a good reason why it's there, to protect your brain from all the toxic chemicals, and also to enable the brain to maintain normal ionic gradients with potassium and sodium and calcium, for example. So this will be largely asymptomatic initially. Gradually, the person will notice less ability to concentrate, brain fog, that sort of thing. And then later, as they're older, now you've already diffusely damaged this blood-brain barrier, and you're getting all kinds of chemicals leaking into the brain. You're having progressive worsening neuron dysfunction. Okay, so anyways, that's kind of an overview of the microvascular or neurovascular unit, it's sometimes called, and neurovascular coupling, adjusting or titrating the amount of oxygen and glucose delivery from blood flow to the level of neuronal activity. And the most interesting thing about this whole talk, I thought by far, was that idea of retrograde vasodilation, based on the amount of neuronal activity whereby the active neurons send especially potassium to the endothelial cells, and it then uses that to communicate to the more proximal part of the artery, vasodilate, so we can get some more oxygen and glucose over here. So anyways, I thought that was interesting.